Welcome, deep divers, as we explore the intricate systems of the human body. Today, we're focusing on two really vital areas of the lower limb. We'll be tackling the complex network of the lumbosacral plexus and then the remarkable engineering of the knee joint. Our goal today, it's really to cut through all that complexity. We want to transform these essential anatomical structures, get them out of the dense textbook pages and make them something truly understandable, memorable, and importantly, readily recallable. This deep dive is crafted especially for you if you're navigating the exciting, maybe sometimes overwhelming world of medicine and trying to build that foundational knowledge.
Absolutely, and that foundational understanding is just so crucial. This isn't just about memorizing facts for an exam. It's really about building the groundwork for every single patient interaction, every diagnostic challenge you're going to face. So today, we're aiming to give you some tools, think vivid metaphors, strong anchors, maybe some practical acronyms, things to help create a robust and reliable knowledge base.
Okay, right. Let's unpack this then. We're talking about the body's sophisticated electrical wiring system for the lower limb, essentially. And alongside that, one of its most essential joints, but also one that's pretty vulnerable, wouldn't you say?
Definitely vulnerable.
Get ready for some clearer insights that will hopefully make these concepts really click. So let's start with the lumbosacral plexus. Think of it as the main electrical grid, maybe the command center for your entire lower limb. It's not just one big bundle, though. It's actually two distinct networks, although they are connected. The lumbar plexus and the sacral plexus. This is really where all the crucial nerves that, power and sense your legs and feet actually begin their journey down.
Exactly. And understanding where they come from gives us our first big clue. The lumbar plexus. This primarily rises from the L1 through L4 spinal nerves. So those are the nerves exiting the lumbar spine, your lower back. It's tucked away, strategically placed deep within the psoas major muscle, that big muscle that helps you lift your leg, like marching. And here's a key pattern. Nerves from the lumbar plexus generally innervate the anterior structures of the thigh, the front part.
Okay.
Then we have the sacral plexus. This one originates from spinal nerves L4 down to S4. So it picks up where the lumbar leaves off and adds the sacral roots. This plexus lies caudal, which just means below the lumbar plexus, and its branches mostly head towards the posterior structures of the lower limb, the back of your leg and foot.
Ah, okay. So there's already a kind of geographical division of labor there, front versus back, mostly.
Yeah, on it. A geographical split in their main roles, but all interconnected.
That's a great way to map it out. A clear division, but part of one essential network. And from this incredible network, three major nerves emerge as your primary power lines for the lower limb. We can maybe anchor these with a simple acronym, FOS. Just think FOS. These are your foundational three.
Good one. FOS, that's the femoral nerve, the obturator nerve, and the big one, the sciatic nerve.
Right.
And each of these FOS nerves has a critical territory it covers. The femoral nerve, generally coming from L2, L3, and L4 spinal nerves, is primarily responsible for the muscles in the front of your thigh, their quadriceps, for instance.
Okay.
The obturator nerve, also mostly from L2, L3, and L4, takes care of the medial thigh muscles. Those are often called the adductor muscles. They bring your leg towards the midline.
Adductors, right, squeezing the legs together.
Exactly. And finally, the sciatic nerve. This is the largest nerve in the body. It originates from a broader range, L4 all the way down to S3. This powerhouse nerve first hits your hamstrings, the back of the thigh, and then through its major branches, it handles both motor control and sensation for pretty much the rest of the leg and the foot.
Wow. Okay. So as we dive deeper into these nerves and start to understand which specific spinal nerve roots contribute to each one.
Yeah.
I like your idea of thinking about it like building a diagnostic map. Like if a patient comes in with, say, weakness or numbness in a specific area, knowing which wires connect to which regions can start to tell you exactly where the problem might be coming from.
Precisely.
This map helps you pinpoint where the electrical circuit might be disrupted. We should definitely keep coming back to that idea.
Let's do that. Let's really decode those major nerves now, focusing on their key sensory and motor roles and those all-important root values. First up, the femoral nerve, primarily from L2, L3, and L4. Sensory-wise, its reach covers the skin on the front of the thigh, and it actually extends down into parts of the leg and even the foot through a branch called the saphenous nerve.
Okay.
Motor-wise, it's a real workhorse. It supplies the anterior thigh muscles like the quadriceps, those big muscles on the front that extend your knee,
Right.
and also the sartorius, which is that long muscle that helps you cross your legs.
Right.
And here's a little anchor to help remember its roots. L2, 3, 4, kick the door. Because, well, the quadriceps are essential for picking.
Huh, I like that. L2, 3, 4, kick the door. Easy enough. Okay, what's next?
Next up, the obturator nerve, also originating from L2, L3, and L4. On the sensory side, it supplies the skin of the medial thigh, the inner thigh. And crucially, it provides sensation to both the hip and knee joints themselves.
Ah, interesting. Joint sensation, too.
Yes. And its motor function. It controls those adductor muscles, allowing you to, bring your legs together. For this one, maybe try L2, 3, 4, obturator to the core, because those adductors often feel like deep, sort of central muscles of the medial thigh.
L2, 3, 4, obturator to the core. Okay, I can work with that. And there were a couple of others you mentioned.
Yeah, just quickly. The lateral femoral cutaneous nerve, mainly from L2 and L3. This one's purely sensory, gives you feeling on the skin of your lateral or outer thigh. And the genitofemoral nerve. It has sensory bits for the skin of the groin area and anterior thigh, plus a motor component to the cremaster muscle in males.
Got it. Those anchors definitely help simplify what feels like a lot of detail at first. Now, let's talk about that powerhouse, the sciatic nerve.
Indeed. The sciatic nerve, as we said, is formed from L4 all the way down to S3, huge range. Its primary motor role initially is supplying the hamstrings, the muscles on the back of your thigh, but it doesn't stop there, not at all. It then branches into two really crucial nerves, the tibial nerve and the common fibular nerve, which you might also hear called the peroneal nerve.
Right, tibial and common fibular.
The tibial nerve handles sensation for the back of the leg and the sole of the foot. Motor-wise, it controls muscles in the back of the leg and those tiny muscles within the foot itself, the intrinsic foot muscles.
Okay.
The common fibular nerve, on the other hand, gives sensation to the front and outer leg and the top of the foot, the dorsum. And its motor control goes to muscles like the tibialis anterior, which lifts your foot up dorsiflexion, and the muscles that extend your toes.
So they really divide up the lower leg and foot duties.
They do. And for the sciatic nerve's broad root value range, you could remember L4, S3, sciatic's decree.
L4 to S3, sciatic's decree. Nice one. Are there other key nerves from the sacral plexus we should know?
Definitely. Beyond the sciatic, the sacral plexus gives rise to some other important players. There's the superior gluteal nerve from L4, L5, and S1. This controls the gluteus medius and minimus muscles. These are super important for stabilizing your pelvis when you walk. They stop your hip from dropping on the opposite side. And it also supplies the tensor fasciae latae, a hip muscle.
Ah, the hip abductors. Okay.
Then the inferior gluteal nerve from L5, S1, and S2. This one powers the big gluteus maximus, your largest buttock muscle, crucial for extending your hip, like when climbing stairs or standing up from a chair.
Makes sense.
We also have the posterior femoral cutaneous nerve. This sensory supplies the skin of the lower buttocks, the back of the thigh, and that diamond-shaped space behind your knee, the popliteal fossa. And finally, the pudendal nerve from S2, S3, and S4. This is a big one for controlling the muscles of the perineum, the pelvic floor area, and providing sensation to the external genitalia and anus.
Wow, quite a list from the sacral plexus. Is there a mnemonic for those?
There is a common one. To help remember some of those key sacral plexus nerves, some Irish sailors, Pester Polly, that stands for superior gluteal, inferior gluteal, sciatic, posterior femoral cutaneous, and pudendal.
Some Irish sailors, Pester Polly. Okay, that's helpful. And just going back to our diagnostic map idea for a second. Say a patient comes in and they literally cannot extend their knee, or it's incredibly weak. Knowing that the femoral nerve, primarily L2, L3, L4, controls the quadriceps, that immediately points you towards that specific nerve's pathway, right?
Exactly. It helps you narrow down where a problem like a lesion or compression might be. Is it high up at the spinal roots? Is it somewhere in the plexus itself? Or is it further down the nerve's course? This understanding is a direct route to clinical reasoning. It's not just abstract anatomy.
That really does highlight the power of this knowledge. It feels less like memorization and more like having a troubleshooting guide for the human body.
Okay, brilliant. Let's shift gears now. From the body's intricate wiring to what I think is just a truly remarkable piece of biomechanical engineering, the knee joint itself. It's this structure that manages an incredible balance between needing to be strong and stable, but also flexible enough for movement.
It really is a masterpiece. Fundamentally, the knee is what we call a modified synovial hinge joint.
Okay, break that down. Synovial hinge, modified.
Right. Synovial means it's a joint type that has a capsule containing synovial fluid. That's a lubricant reducing friction. Hinge means its primary movement is like a door hinge, flexion and extension, bending and straightening. And modified means it's not just a simple hinge. It also allows for a little bit of rotation, especially when the knee is flexed.
Ah, and it's actually made up of 3 distinct contact points, 3 articulations. There are 2 tibiofemoral articulations. That's where the rounded ends, the condyles of your thigh bone, the femur, meet the top surface of your main shin bone, the tibia, medial and lateral ones. And then there's 1 patellofemoral articulation. That's where the back surface of your kneecap, the patella, glides along a groove on the front of your femur.
So 3 joints within the main knee joint complex, essentially.
You could think of it that way, yes. 3 articular surfaces working together.
And to really appreciate how the knee works, we probably need to properly meet the bones involved.
Good idea. Let's look at the osteology, the bones. First, the tibia. This is your main weight-bearing bone in the lower leg. It's like the pillar of the lower leg. It receives all that weight coming down from the femur and transmits it down towards your foot.
Right, the big one.
Then you have the fibula, running alongside it laterally. This is more like the accessory bone. Crucially, it does not bear weight from the knee. Its main jobs are providing attachment points for muscles and helping to stabilize the ankle joint down below. It's not actually part of the knee joint articulation itself.
That's a really key point. Fibula isn't part of the knee joint proper.
Okay.
And the kneecap.
Ah, the patella, your kneecap. It's a special type of bone called a sesamoid bone. That just means it's a bone embedded within a tendon, in this case, the tendon of your quadriceps muscle, which continues down as the patellar ligament. You can think of it as the knee's intelligent pulley system. It sits out front, gliding in that groove on the femur. And by doing that, it significantly improves the leverage, the mechanical advantage of your quadriceps muscles when you straighten your knee. Makes extension much more powerful and efficient.
Fascinating. It's amazing how each bone has such a specific role. And with all these bits working together, the knee allows for, well, impressive movements, flexion, extension. And you mentioned that subtle rotation during flexion.
Yes, and that rotational capacity is part of something really cool called the locking mechanism of the knee. When you fully extend your knee, straighten it right out, the femur actually rotates slightly, medially turns inward on the tibia. This locks the joint into a very stable position. It makes standing for long periods much more energy efficient because you don't need as much active muscle contraction to keep the legs straight.
Ah, the screw-home mechanism, I think I've heard it called.
Exactly, the screw-home mechanism. And then to unlock it when you want to start bending your knee, flexing it, a small but important muscle called the popliteus muscle, located behind the knee, contracts. This causes a slight lateral outward rotation of the femur on the tibia. That little rotation unscrews or unlocks the joint, allowing smooth flexion to begin. It's a really neat coordinated movement.
It really is. Okay, so considering the knee's incredible mobility and the sheer forces it must withstand every day, walking, running, jumping, what do you think are the absolute critical components, maybe the unsung heroes, that prevent it from just collapsing or dislocating with every step? Beyond the bones and the big muscles we can see, what provides both that flexibility and the unwavering support? Let's think about those. Maybe the unseen guardians of the knee. We should explore those next.
That's an excellent question. It really gets to the heart of knee stability. You're right. Muscles are hugely important, but the answer really lies heavily in its complex network of ligaments and also structures called the menisci. These really are the unseen guardians you're asking about. They provide passive stability.
Okay, menisci and ligaments. Let's start with the menisci. What exactly are they?
The menisci are 2 C-shaped or crescent-shaped pieces of tough, rubbery fibrocartilage. They sit right on top of the flat tibial plateau, nestled between the femur and the tibia. Think of them as the knee's shock absorbers and deepeners. They do 2 main things. They deepen the relatively flat surface of the tibia, making it a more stable cup for the rounded femoral condyles to sit in. And they help distribute the weight-bearing forces more evenly across the joint, reducing stress on the articular cartilage. And they absorb shock.
So they improve the fit and cushion the impact. Got it. Are the 2 menisci the same?
Not quite. There's a medial meniscus on the inner side and a lateral meniscus on the outer side. The medial meniscus is larger, more C-shaped. It's attached quite firmly anteriorly and posteriorly to the tibia's intercondylar areas. And significantly, its outer edge is firmly attached to the deep part of the tibial or medial collateral ligament, MCL. This makes it less movable, kind of like a fixed cushion.
Okay, attached to the MCL. That sounds important clinically.
It is. We'll come back to that. In contrast, the lateral meniscus is smaller, more O-shaped or circular, and much more movable. Crucially, It is not attached to the fibular or lateral collateral ligament, LCL. This freedom allows it to glide more during movement, making it more flexible, like a floating cushion.
Fixed medial, floating lateral. Okay, so that's the menisci. What about the ligaments?
Right, the ligaments of the knee, these are like strong ropes holding the bones together. We can divide them into ligaments outside the joint capsule, extra-articular, and inside the joint capsule, intra-articular. The main extra-articular ligaments act like side braces or fences, preventing the knee from buckling inwards or outwards. On the outside, you have the fibular lateral collateral ligament, LCL. You can think of it as the lateral fence. It runs from the femur down to the head of the fibula. On the inner side, you have the tibial medial collateral ligament, MCL, the medial fence. This one runs from the femur down to the tibia. And remember, its middle deep fibers are attached to that medial meniscus.
Ah, there's that connection again. So if you injure the MCL.
You often injure the medial meniscus too. It's a common pairing in injuries, sometimes called the unhappy triad if the ACL is also involved.
Right. And how do you test these usually?
We use stress tests. For the MCL, we apply a valgus stress, gently pushing the lower leg outwards while stabilizing the thigh. If the inner side of the knee gaps open too much, the MCL might be injured. For the LCL, we apply a varus stress, pushing the lower leg inwards. If the outer side gaps, the LCL could be damaged. A classic example is a blow to the outside of the knee often injures the MCL due to that valgus force.
Okay, valgus for MCL, varus for LCL. Makes sense. Now, what about the ligaments inside the joint?
Those are the intra-articular ligaments, and the most famous are the cruciates, so named because they cross each other, forming an X deep within the joint. You could call them the knee's internal X factor, crucial for front-to-back stability.
The ACL and PCL.
Exactly. The Anterior Cruciate Ligament, ACL, runs from the anterior part of the tibia front, upwards and backwards, to attach to the femur. Its main job is to resist anterior movement and rotation of the tibia on the femur. Basically, it stops your shin bone from sliding too far forward relative to your thigh bone. It's critical for stability during cutting and pivoting movements.
Okay, prevents forward sliding of the tibia.
And the Posterior Cruciate Ligament, PCL, runs from the posterior part of the tibia back, upwards and forwards to attach to the femur. Logically, this one resists posterior movement of the tibia. It stops the shin bone from sliding too far backward on the thigh bone, like when your knee hits the dashboard in a car accident.
Got it. ACL prevents forward, PCL prevents backward sliding.
Precisely. And a common way to injure the ACL, unfortunately, is hyperextension when the knee is forced unnaturally straight or backward, or sudden stops and changes in direction.
Wow. So, just to paint that picture clearly, the menisci are like custom cushions, deepening the joint and absorbing shock. Then the cruciates, the ACL and PCL, are like internal seatbelts, stopping that front-to-back sliding. And the collaterals, MCL and LCL, are the sturdy side fences, keeping everything lined up side to side.
That's a great summary.
No wonder knee injuries are so common, especially in sports. There are just so many vital parts that need to work perfectly together.
Absolutely, and it doesn't quite stop there. Beyond these core stabilizers, the menisci and ligaments, there are other important structures around the knee that contribute to its smooth function and protection.
Oh, like what else?
Well, for instance, the bursae of the knee. These are little fluid-filled sacs, sort of like tiny water balloons. They act as the knee's friction-reducing airbags. They sit between structures that move over each other, like tendons gliding over bone or skin moving over the kneecap, and they reduce friction.
Ah, bursae. I've heard of bursitis.
Exactly. There are quite a few around the knee, but common ones include the prepatellar bursa, right in front of the kneecap, and the suprapatellar bursa, just above it, often connected to the joint cavity. When these get inflamed, usually from repetitive pressure or friction, you get bursitis. That causes swelling and pain. Think of conditions sometimes called housemaid's knee, prepatellar, or clergyman's knee, infrapatellar.
Okay, so they're like little lubricating cushions. What else?
Then there's the incredibly rich blood supply to the knee. This comes mainly from branches of the femoral artery above the knee and the popliteal artery behind the knee, called the genicular arteries. What's really fascinating here is the extensive network of connections, or anastomoses. These arteries form around the knee. Think of it like a vital circulatory roundabout. There are superior, inferior, medial, and lateral genicular arteries all connecting up. This rich network ensures that the joint gets continuous blood flow from multiple directions, which is important because blood supply can be temporarily pinched off in certain knee positions or even damaged in an injury. This network provides backup routes.
A circulatory roundabout, that's a good visual. Ensures the supply keeps flowing.
Precisely. And finally, just to tie things back, the nerve supply to the knee joint itself. This really brings us full circle back to our initial discussion of the lumbosacral plexus. The knee joint capsule and ligaments are richly innervated, receiving branches primarily from the femoral, tibial, and common fibular nerves. So that electrical grid we started with directly wires up the knee joint too, providing sensation, including pain and proprioception, your sense of joint position.
What an incredible journey we've taken. We've gone from that intricate electrical grid of the lumbosacral plexus, understanding how the lower limb gets its power and sensation, all the way down to the details, the biomechanical masterpiece that is the knee joint, this structure that allows us to stand, walk, run, and jump with such amazing precision and power.
It's quite something when you put it all together. And remember the value of these foundational concepts as you learn. Our diagnostic map for figuring out nerve issues and those unseen guardians of the knee, the menisci and ligaments, these aren't just abstract names to memorize for a test. They really represent functions, vulnerabilities, and provide genuine clinical insights that are waiting for you to apply when you see a patient. Understanding these pieces empowers your clinical reasoning.
Absolutely. This deep dive has hopefully offered you a bit of a shortcut to understanding, retaining, and crucially recalling the core anatomy of the lumbosacral plexus and the knee joint. But of course, it's just the beginning of your journey into the incredible complexity and really the elegance of the human body.
Well said. So maybe here's a final thought for you, the listener, to mull over. Considering that locking mechanism of the knee, that screw-home rotation that allows full extension to be maintained with minimal muscle effort, what evolutionary advantage might that specific feature have provided our early ancestors in their daily lives? Perhaps something beyond just standing around effortlessly. Think about that until our next deep dive.
Ooh, that's a fantastic question to ponder. Evolution and biomechanics meeting. Brilliant. Thank you so much for joining us on this deep dive today. Keep digging deeper, everyone, and we'll catch you next time.